Hi, my name is Pearl Ma. Thank you for the opportunity to present. Thank you. The authors and I have no relevant disclosures to provide. So the opioid epidemic is a major issue on the local and national level, and especially in our surgical patients, this is emerging. A lot of the patients that are opioid naive can become opioid dependent. In recent studies in JAMA, there's up to a 6% rate of new opioid chronic dependency after their major or minor operation, and so this is a significant finding. In bariatric patients, this is also pretty relevant. We have a higher incidence of chronic pain, depression, and potential for cross-addiction after surgery, leading to chronic opioid use. And in some papers, this chronic opioid use that they had before the surgery may be actually higher years after their bariatric surgery. So measures to do opioid-sparing regimens is now emerging and becoming more popular, especially with our enhanced recovery after surgery protocols. This is also called enhanced recovery after bariatric surgery, fast track, enhanced recovery, SMART program from SAGES, as well as the energy that's recently introduced by Dr. Brett Howers as well. So otherwise, what we did was we implemented this program and we performed a retrospective study of the patients that underwent this program. We did this at one center in Fresno, and all the patients that underwent laparoscopic room-wide gastric bypass or sleeve gastrectomy, excluding those that underwent conversion operations from June 2016 to October 2017. Our goal in this study was not necessarily reduction of length of stay, as most of the literature out there about ERABS and bariatric surgeries, because our length of stay was only about a day and a half normally. And so we wanted to see, could we go potentially opioid-free after our operations? And so we converted all the opioids into a morphine equivalent unit. And secondary outcomes include pain control scores, length of stay, readmissions, and complications as well. And so this is just a depiction. With our ERABS protocol, we had a multidisciplinary approach to this where we had nursing as well as the buy-in from the anesthesia and such. But the major changes that we did from our standard protocol is that we did a lot of preoperative education with these patients and started preoperative pain control early on with gabapentin as well as Tylenol the night before surgery. They continued on liquid diet. We did not do carb loading in our patients as our adherence was difficult with our Medi-Cal patients. Overall, the patients continued clear liquids up until the time of surgery, approximately 2 hours beforehand. They also received another dose of gabapentin. We placed scopolamine patches, gave them melatonin, as well as dexamethasone. We started to routinely introduce liposomal bupivacaine at injection at the trocar sites, and we did a goal-directed therapy with our fluids with anesthesia. Our liposomal bupivacaine we used was Exparel. At that time, we were able to use on a significant amount of patients. We just injected it directly at the surgical site. And this is a medication that has a slow release over 72 hours from the tissue. And so overall, the biggest thing that we did was that we changed that from just simply directing that, injecting Marcaine into the incision. And then postoperatively, we really encouraged the patients to walk even if they were in recovery for a prolonged period of time, and really worked with the nursing to use non-opioid medications to really not go to the first line as opioids the first time if they have pain. We also put them on scheduled Toradol and continue the gabapentin as well as the Tylenol. We also discontinued PCA use, which was significant in our patients, and limited the amount of narcotics that they were able to go home with. So overall, within this time period, over a year, we had about 1,300 patients that underwent sleeve or gastric bypass. And so we grouped them in three settings here. The first one is before we did any standard changes. The second one is when we introduced Exparel routinely. And then the third group is when we actually introduced ERABS and continued using Exparel as well. And so this was a consecutive sampling of these patients. Demographic-wise, pretty similar. Main BMI was about 45 or so, but otherwise nothing too significant here between the three groups. The biggest thing that we found was the pain level scores on postoperative day 1. Comparing our ERABS with our Exparel to the standard protocol, we had a 46.3 decline in pain scores. In terms of morphine equivalent units, we had a decline of approximately 60%. And we were able to get about 45% of the patients with no narcotics on the floor, and a total of 10% of patients without any narcotics during their hospitalization, but this was not statistically significant. When we looked at the three different groups, comparing the two, there was a little bit of a difference when we just started using Exparel in terms of the decrease in the MEUs. But overall, the biggest effect was the ERAS with the liposomal bupivacaine. Our length of stay as well as declined, but really it went from 1.5 days to 1.48 or so. Our readmission rate also declined significantly too. And what we found was that probably the most significant thing was the unexplained abdominal pain. Our readmissions that we had before we used Exparel or the ERAS, we had some unexplained abdominal pain that came in that worked up and couldn't find any significant findings for them. And we didn't really have that problem after we started the Exparel and ERAS. So overall, we were able to decrease our pain levels on post-op day 1 by 46%, and the morphine equivalent used by almost 60%, and our readmission rates also declined. Limitations of the study is retrospective in nature, and we did a consecutive sampling of those patients, which has that bias with that as well. The data abstraction was difficult because we had used PCA dosing in the standard group. It was hard to abstract how much narcotics that they had received. One limitation is also we did not track how much narcotics they used as an outpatient when they went home, as well as those that had it coming in with a pre-existing chronic opioid dependency too. So because we did the standard protocol, and then we did Exparel, and then we did ERAS with Exparel, it was hard to tell what was the true effect of Exparel itself. And so overall, this was a multidisciplinary coordinated effort. Really, this worked for our institution. We worked with pharmacy as well as our administration. And not to say that our protocol is the one and only. It's whatever works in your institution and as well as with your pharmacy and nursing staff and your budget. We were able to significantly reduce the postoperative narcotic use as well as length of stay, but I don't think this is necessarily just adding Exparel really resulted in a big change. It was really the ERAS protocol that really showed the biggest effect. And so future plans to see how this reflects within the energy project that Dr. Brett Howard is coming up with the MBSA QUIP. Hopefully we can contribute to that literature as well. So thank you very much, and I'll take your questions.